All right, the title of this program is going to be Colorectal Cancer Awareness Month. If I say it too fast, I won't be successful at getting that out. And our guest today is Dr. Michael Nerney. And good afternoon, Dr. Nerney. How are you doing today?
I'm doing great. How about you?
Fantastic. Well, let's just, a lot of people may not have met you. You've been here, I think you said 4 years now in our community. Where did you originally come from?
I was originally born in Marietta, Georgia. Grew up in Southeast Virginia near Hampton, if you would be aware of that area.
Yes.
And went to college in Virginia at Hampden-Sydney College, medical school in Virginia at Eastern Virginia Medical School in Norfolk. Then I did a 5-year internship residency in surgery at University of Florida in Gainesville.
Mm-hmm.
After that came 3 active duty Air Force years in North Dakota, up there with the missiles and bombers. And then I've been 28 years in Largo, Florida, which is near Clearwater, St. Petersburg, Tampa Bay area, at a large multi-specialty practice there, about 100 doctors.
Wow.
And then I've been here coming up on 4 years.
4 years.
Erlanger Western Carolina Hospital.
Fantastic. Well, how do you enjoy the mountains of North Carolina?
I'm only loving it. Yeah, I mean, the people are great. We love the scenery. We love the lack of cars on the road. It's easy to get around. We think we've enhanced our lives to come here, my wife and I.
Fantastic. I never enjoyed driving Atlanta traffic. I used to live in Raleigh-Durham area.
Yeah, I'd like to avoid that as best as I can.
When they have to add extra belt lines around the city because of the too much traffic on the first belt line, there's a problem. And that's what happened with Raleigh-Durham area. All right. Well, tell us a little bit about yourself and what you're passionate about in medicine.
Well, let me see. I'm a board-certified general surgeon. I've been practicing it for a bunch of years now, 28 and 3 and 4, so a bunch of years. And I really enjoy the laparoscopic side of surgery, so I do a lot of laparoscopic colorectal surgery, and as well as appendectomies and cholecystectomies, removal of the gallbladder. I do breast diseases, too, for benign and malignant disease. And I do a lot of endoscopy. It came across probably as my interest in colorectal surgery. I'm a very busy general surgeon, but I probably do about 1,000 endoscopies a year.
Wow.
Yeah.
You stay pretty busy.
Yeah, I enjoy that.
Well, what exactly does colorectal cancer include, and is it common?
Well, let me see. Colorectal cancer is kind of a combination term. You can have colon cancer, and you have rectal cancer, which is down close to the anus. But because the diseases behave very similarly, they get grouped into one called colorectal cancer. And it is very common. There's probably about 135,000 people a year that come down with this. It's our goal to make it less common.
Is that here in the U.S.?
That's here in the U.S.
Wow.
It's very prevalent, yeah.
And how is it usually diagnosed?
Usually diagnosed through colonoscopy. I mean, there's some other screening procedures that you can use that are, in my mind, very far inferior to colonoscopy. Colonoscopy offers the benefit to take care of early disease in the colon to prevent a cancer. It's more accurate than other methods, and it's simply, I think, the best way to go in terms of being sure that you don't get a cancer. We can prevent colon cancer through colonoscopy.
All right. Well, by the way, off track here, there's messages that sometimes come up from on the screen from viewers.
Yes.
Apparently, your endo team loves you. If I read that correctly.
Well, that's nice of them. I love them too. Yep.
All right. What exactly can a screen find, and what is? I've heard the word polyp. What is a polyp?
So a polyp is a growth on the inner lining of the colon. The inner lining is called the mucosa. And you can have a little growth in there, gets bigger over time. There's actually a DNA problem with the cells that happen there. But left unattended, it gets bigger, then generally degrades. The cells become more bizarre. They become what we term dysplastic, fancy term. And eventually they degrade further to become a cancer. So that's what screening is about, to find these polyps and prevent them by removal from ever becoming a cancer. They're very, I'm not going to say easy to see, but when you've been doing it a while, you can certainly recognize the difference between normal and abnormal tissue in the colon. And that's what the screening's all about. Try to find these polyps, prevent them from becoming a cancer.
All right. So screening recommendations. For example, I just turned 27. Wait, maybe my math is a little bit off. At what age should someone start having screenings, frequency, gender, other risk factors?
Yeah, it kind of varies. The usual age to begin for average risk people, and we stratify people in different risk groups, but for an average person, that is somebody that has no personal history of colon polyps, no family history of colon polyps or termed adenomatous polyps or cancer, their average risk, the American Cancer Society recommends beginning at 45.
Ooh.
It used to be 50. It just got upgraded to 45.
So here I am at 47.
Yeah, well, it's time.
I may be calling you.
Okay, and what was the second part of your question?
As far as frequency, age, gender, and other risk factors.
So frequency varies based, again, on your risk factors. If you have genetic predisposition towards cancer, well, we'd screen you more frequently. If you've had polyps found on a prior colonoscopy, we'd probably screen them, if they're adenomatous, screen you more frequently. So it varies person to person. It varies a lot, and we just have to take all the factors into account at the time and make our best decision when it would be safe for you to come back again and get it done again in an effort to prevent getting a colon cancer.
All right. So you've been in our community for 4 years now, and I'm sure you've had data that you've seen prior to that. Have you seen any colorectal cancer trends in our community?
Well, I wouldn't say necessarily in the community. I mean, I think people are getting better about getting screened in this community, becoming more aware. I certainly do a lot of endoscopies. But in general, in the nation, there's been a great trend for decreasing incidence of colon cancer. I think that's because of the screening. We're preventing people from getting cancers. In fact, it's about a third less now, 30% less over the last 10 years compared to prior to that. So we're doing a good job of screening. All the insurance companies seem to, recommend and go along with it. So,
Well, that's refreshing news.
yeah, it's a good trend.
All right. What exactly does a typical screening include? I know there's myths about discomfort, and how should a person prepare for such a screening?
Well, for colonoscopy screening, you have to clean out the colon. The better job that's done, the better we see, the more diagnostic and therapeutic it is. So it's not such a horrible thing, especially when you consider that you're only doing it every so many years, maybe even as infrequently as every 10 years. And it involves drinking a solution that carries through the entire intestinal tract and washes everything away with it. You have to pretty much stay away from any solid foods on the day of the preparation. You're having clear liquids, and you drink this preparation, of which there are many different varieties, and you have a pretty good diarrhea. There's something called a split dose prep, which is a bit inconvenient, but again, considering that it's not very frequent that you do this, it's worthwhile because it gives you such a better bowel preparation. We can detect things. The colonoscope actually magnifies what we're seeing in there. We can find lesions as small as 1 millimeter. I mean, it's very tiny. So we have very good detail through the colonoscope of what we're dealing with. At any rate, you do your bowel preparation. Don't eat anything or drink anything some number of hours before coming in. We bring in the room, sedate you by vein, and you become unaware totally of what's going on. You have no discomfort during the examination. It seems like lights out, lights on, you're all done already. It can't be. And I've had 3 colonoscopies myself, so I can speak to that. It's not an unpleasant experience. Most patients would claim that the most unpleasant part is the bowel preparation, and maybe it is because it's inconvenient and you're kind of locked up for a day, but well worth it. And the better job that is done, the better we see, the more diagnostic it is.
Well, I'm sure as long as you've been in this field, you've seen a lot of technology changes. What was this like at the beginning of your career as far as technology versus what it is today?
For the colonoscopy?
Yes.
So we used to have scopes where you would actually look in an eyepiece on the end of the scope. So that was right up close to your face the whole time you're working. The controls you have for movement of the head of the colonoscope were right there, and the port where you'd get biopsies and work through was also close to your face. So that was actually kind of dangerous because the fluids would come out and such. These days, because of the advent of CCD chips, it's all video endoscopic. So it's well away from you, working away. So I think the video endoscopes have been the biggest advent in this thing. They give really great definition. You have a high definition picture of what's going on inside of the colon. In the days where you look through the scope, it was like a lot of little tiny light circles that you'd imagine an image through. So it's progressed a lot.
Was in the original days, was there recording involved, or was it just all live looking?
There was no recording involved. It was just live looking. If you wanted to share the experience with somebody else, they had to actually attach a device to the end of the colonoscope. You still saw through it, but part of your light was shared with a little side viewing scope. And so you wouldn't see as well, and you could only teach one person at a time. These days, the picture, the endoscopic picture, comes up on a big old monitor, and everybody in the room can share in the experience in terms of seeing what's going on. So if I'm removing a polyp, my assistant at that, who helps manipulate some of the instruments, can see what I'm doing and help me even better.
And I'm guessing nowadays that video gets recorded so that it can be reviewed later?
We don't usually record them. We take still pictures during the thing to show that we've made our landmarks of getting all the way through the colon, and to show what the polyps were like and show that they're completely removed and that sort of thing. But we don't take a video. As a surgeon, we used to do that early on in the days of laparoscopy for taking out gallbladders and such, and nobody ever looked at them again. So saving a big old video didn't ever seem to make much sense.
But at least you do have a paper trail of still images. That's
Yes.
great. All right, you touched on insurance earlier. Is screening usually covered by insurance, Medicare, commercial insurance, Medicaid, any of those?
All those people cover it. It's so well worthwhile doing to prevent getting a colon cancer, and they all agree with that, and therefore it's covered, Medicaid included.
That's good news. Well, where would someone go to get a screening, and how would you get someone scheduled for this screening?
Most of the people that I see are referred by their physicians, but I do see a number of people that just kind of self-refer. They call up my office and schedule a colonoscopy, or at least an appointment to be seen. I think we do something a little out of the normal in terms of the procedure. A lot of gastroenterologists and surgeons just schedule you, and then on the day meet you and do it. I think we have a little better touch. Myself and my nurse practitioner, Becky Boyer, see people ahead of time, take an exam, get all the historical data, make sure you're safe for the procedure, and answer all the questions that there are about it. So I think the patient feels much better informed than just being kind of in a line one day to meet the person at that time who's going to do the procedure without all the questions answered. So we add a little something there.
All right, Dr. Nerney, complete the following sentence.
Okay.
All right. An ounce of prevention is worth?
A pound of polyps. No. So, no.
A pound of cure, right?
Yeah, of course, yeah.
Are there ways that we can live our lives to avoid colorectal cancer?
Well, maintaining a healthy lifestyle is thought to be beneficial. Avoidance of high fatty foods, getting exercise, having less alcohol. Excuse me, sorry about that. Having less alcohol is a good idea. And, probably taking an aspirin a day, if it's not contraindicated for you, may be helpful. The jury's out on that one, but that may be helpful too. So if you're taking it for your heart, you may be helping your colon in addition.
All right. So you have gone through the screening and you find out that there's something to be concerned about. What treatments are available?
Well, the screening will tell you if you've got a polyp, at which point I guess you're coming back for further colonoscopy. If we unfortunately do find a colon cancer, the great advent in terms of the surgical side of this thing, we discussed the endoscopic changes, is the advent of laparoscopic surgery. Again, compliments to the CCD chip, the little small video cameras. We can see inside the abdomen through small incisions now and actually take out whatever part of the colon or all of the colon through this laparoscopic approach. So it's a much easier recovery than what it used to be. And I actually think it's more accurate. I mean, you've got such great detail on the high-definition monitor. We can very accurately take out the blood vessels and the corresponding lymph nodes that go along with the blood vessels, and get really nice resections done at better patient comfort. So at least as good or better results at better patient comfort.
All right. What percentage of people that get the screenings would you estimate need to have treatment versus everybody's okay?
It's kind of a small number. I mean, we look at what's called the adenoma detection rate for colonoscopy. At least a third of the people that come through, and I think it's a bit higher, have these adenomatous or precancerous polyps. Maybe you've heard that term before, precancerous. It means that kind of polyp that might turn over time. Not every polyp is like that. There's some termed hyperplastic that don't have that same propensity. So a large number of people will come back because they had adenomatous polyps sooner than 10 years, which is about the longest length you get between screening intervals. And then, probably a couple percent end up with something that we have to do something more for, like surgery.
And had they not gotten the screening, then things could have gotten much worse.
Well, all of those people, the adenomatous polyp people, had they not gotten screened and just lived their lives, a good number of those would end up having a colon cancer. That's how we're getting that 30% decrease over the past 10 years is through more screening now in terms of development of cancer of the colon.
Wow. Well, that just shows right now that is a very important process, the screening for everybody to get that meets those requirements.
I agree with you. Incredibly important. And so, it's so easy to have a colonoscopy and get that polyp out. It's a whole lot harder to be found to have a cancer, especially late in the disease, which is the only time symptoms present, you can sense it, and have to go through surgery, maybe chemotherapy and or radiation therapy. It's just so much easier to prevent it than to deal with it after it's there.
Are these screenings usually something that the general doctor of the patient refers patients to, or do people just know that I'm currently of that age and I have a history in my family? Do they just usually check them themselves for these screenings?
I'd say most of my patients come referred by a physician who's following their screening not only for their colon, but say their prostate or the breast, cervical, pap smears, things like that, mammograms. Those are all screening procedures we do to try to either find a disease early where it's preventable or to find it early where it's more curable. So this is just one of those things that primary care physicians are always looking out for. When was your last colonoscopy? And trying to decide, do you need one now?
Where's your office located currently?
We're over in the next to the Erlanger Western Carolina Hospital. There's a row of buildings to the left of that if you're facing the hospital.
Right.
And the medical office buildings. We're over in there in Suite I, 145
Suite
Medical Park
I.
Drive, I think.
All right. Well, very good. Anything else that we need to cover that I haven't asked you about so far?
No, I think a good summary. I couldn't implore people enough how important it is to get this done and how much more favorable it is to prevent the cancer than to deal with it later. So get your screenings.
All right. Well, Dr. Nerney, we appreciate your taking the time to be with us today, and I think a lot of folks out there, whether it be Facebook Live, radio or TV or internet, have gotten a lot of great information because this is something that usually people don't talk about in a normal, everyday conversation.
Maybe one thing we could consider touching on that I feel a bit passionate about is this Cologuard. A lot of people, it's advertised on TV, and I see people coming in that have had a Cologuard, and maybe it turned up positive. Are you familiar with that?
No.
It's a test that looks at blood in the stool as well as for DNA problems in the stool brought on by polyps or cancer. And it has about a 13% false positive rate. It means you send in your test of stool from your home, and they say, well, you might have a problem in there. It's not correct 13% of the time. It causes a lot of concern. The follow-up is always to get colonoscopy. But worse than that is that if you have a cancer, 8% of the time, it's in their literature, 8% of the time it misses it. I don't know about you. I don't want to be almost 1 in 10 that it missed my cancer, and I don't want to wait till I have a cancer to pay attention. If it's looking for polyps, it's wrong more than half of the time in terms of detection for polyps. So it's something maybe reserved for people who are in poor health. It's a test that should be done only on average risk people, not people that have had a history of polyps or at higher risk categories. So I would say in lieu of Cologuard, which sounds easy, go for a more efficacious test like the colonoscopy.
All right. Well, you provided a lot of great information today, and I really appreciate your being on the show and providing that information to our viewers and listeners. So if anyone has any other questions or needs to get in touch with your office with questions, how can they reach you?
That's going to sound a little crazy. I don't ever call my office, so I don't know the phone number, but call Erlanger Western Carolina Hospital and ask to be directed to my office, and be happy to see anybody who has the need to have this done.
And I believe Erlanger Western Carolina is 837-8161.
That sounds correct to me.
837-8161, and asked to be transferred to the office of Dr. Michael Nerney. All right. Well, thank you so much.
And thanks for having me.
You have a great day.